So the remaining part of poisoning will be continued later. So in the ops topic, two important topics. One is your eclampsia and pre-eclampsia, that is your hypertensive disorders of pregnancy I'll be taking, and the other one is your postpartum hemorrhage. Okay. So the outline of the topic would be the physiological changes in pregnancy that are actually related to your PIH, the definitions, the pathophysiology, the screening and diagnosis, and last one would be the management. So the physiological changes which are very, very important for the PIH are first the hemodynamic changes. Okay, so this has been divided into first, second, and third trimester and during labor. So in the hemodynamic components, your cardiac output. So your cardiac output will be slightly elevated in your first trimester compared to your baseline. Second trimester, a little higher. Second and third trimester, and during labor, your cardiac output will be at the highest. Now coming to your systemic vascular resistance. It is reduced in the first trimester, comparatively further reduced in your second and third trimester. Heart rate, it is usually increased during third trimester and labor because of the labor pain that is present. But coming to your BP changes, if you see in the first and the second trimester, your BP is actually on the lower side compared to the normal BP. And in the third trimester, it could be usually normal. Okay. So these hemodynamic changes are very, very important to further go into the topic. Now, what happened to the systolic BP? As I told you, BP will be lower compared to the normal BP. So, systolic blood pressure will be decreased by 4 to 6 mmHg. Diastolic blood pressure will be decreased by 8 to 15 mmHg. Your mean arterial pressure will be decreased 6 to 10 mmHg. Whereas your heart rate, as I told, will be increased. Your stroke volume and your cardiac output both will be increased. Now coming to the spectrum of this hypertensive disorders. Okay, so what is so the main important factor is your BP. So any pregnant lady with a systolic blood pressure of more than or equal to 140 mmHg, and sorry for this, the diastolic here should be more than or equal to 90 mmHg. Okay, so systolic more than or equal to 140, diastolic more than equal to 90. Then see the gestational age of the patient. Okay, so whether this pregnant lady's gestational is less than 20 weeks or more than or equal to 20 weeks. Suppose if it is less than 20 weeks and the patient has a BP of this much, then that is known as chronic hypertension. Okay, suppose if the gestational is more than or equal to 20 weeks, then you should see whether there is any target organ involvement or not. If there is no involvement of a target organ, then that is known as gestational hypertension. But if the BP is on the higher side, the gestational age is more than 20 weeks, and there is any target organ involvement, then that is your preeclampsia, eclampsia, and your HELP syndrome. Okay. Now coming to the gestational hypertension. So this also depends upon three important things. One is if the hypertension persists more than 12 weeks postpartum. So patient came here at around 26 weeks. There is no target organ involvement. BP is on the higher side. You have diagnosed as gestational hypertension. Post delivery, when you measured after 12 weeks, still the patient's BP is on the higher side. That is known as chronic hypertension. So you have two definitions for chronic hypertension. Suppose what, depending upon the gestational age. Okay. Now second group comes if the hypertension persists less than 12 weeks postpartum, that is known as transient hypertension of pregnancy. Whereas this gestational hypertension who doesn't have a target organ involvement, around 10 to 50% slowly progresses to involve one of the organs, and that time again you need to call it as preeclampsia, eclampsia, or HELP syndrome. Okay. Okay, easy way to remember the definitions if you just put this diagram. Okay. So you came to know about the definition of chronic hypertension and gestational hypertension. So I'm not going in detail about this. So we will go to the other definitions. So preeclampsia and eclampsia. So this preeclampsia can be further divided into without severe symptoms, with severe symptoms. So without severe symptoms, systolic BP, diastolic BP, yes, which is measured at least two occasions, 4 hours apart, gestational age of more than 20 weeks with proteinuria. So how much should be the proteinuria? Very, very important. More than 300 mg on 24-hour urine protein collection, or if you are doing the dipstick, 0.3 mg or 2 plus dipstick. Okay. Or women with new onset hypertension 48 hours to 6 weeks after delivery is also known as preeclampsia. Now with severe symptoms. So with severe symptoms means along with the proteinuria, there is evidence of end organ injury. If there is an end organ injury, then it is severe preeclampsia, or your BP is more than or equal to 160 mmHg systolic BP, and your diastolic BP is more than or equal to 110 mmHg on at least two occasions 4 hours apart, or persistent severe hypertension requiring IV antihypertensives to control your systolic or the diastolic blood pressure. Okay, this is with severe symptoms. End organ failure, severe symptoms, or your BP is more than 160 by 110. That is severe features. Okay, this is about preeclampsia definition. So as I told here in the previous one, gestational hypertension with one of the end organ involvement. So from that time I'm telling end organ involvement, end organ involvement. What is this? Okay. Any neurological complications, like if the patient has eclampsia, altered mental status, development of stroke, blindness, severe headaches, or persistent visual impairment, then that is end organ involvement in the form of CNS involvement. Second, respiratory pulmonary edema. Third, hematological, your HELP syndrome or any DIC. Fourth, kidney AKI. Fifth, liver involvement in the form of elevated aminotransferases or right upper quadrant or epigastric pain. And fifth one is related to the fetus, that is the uteroplacental insufficiency. Okay, if any one of these is present, then it is a severe preeclampsia, end organ involvement. Okay. So that is about your preeclampsia. Now what is superimposed preeclampsia on chronic hypertension? Okay. So it is nothing but sudden worsening of BP control and need to escalate your antihypertensive therapy, or a new onset of proteinuria or a sudden increase in proteinuria in a patient with a known proteinuria. New onset or sudden increase in proteinuria, or significant new target involvement which is consistent with preeclampsia, that is more than 20 weeks of gestation or postpartum. Okay, I think you need not to remember this, not much important. Just gestational chronic hypertension, gestational hypertension, the different types of gestational hypertension, and what is preeclampsia and eclampsia. More than enough. Okay, but you should remember the definitions. When you are writing the definition, you should write BP of this much measured on two occasions, 4 hours apart. Everything has to be mentioned. You can't mention just BP this much is with 20 weeks of gestation is preeclampsia. No. Okay, so your definition should be proper enough. Now coming to eclampsia. Eclampsia is a severe life-threatening manifestation of preeclampsia. So here, usually if the patient has seizures, so a preeclamptic seizures, having a preeclamptic patient having seizures is eclampsia. So convulsions during pregnancy or during postpartum, which could be tonic-clonic, focal or multifocal, new onset, unexplained by other neurological pathology, and associated with headaches or visual changes prior to a seizure. Okay, so these are the features of convulsions which a eclamptic patients has. Okay, and you should consider other underlying cerebral condition if the seizure occurs 2 to 3 days postpartum, And patient, even on magnesium sulfate, if the patient has seizures, then you should think of the other causes like press or some other things. Okay, icy bleed. Okay, so that other causes has to be thought of. Okay. So these are just the differences between preeclampsia, chronic hypertension, superimposed preeclampsia and chronic hypertension. If you have time, go through it. Otherwise, you can just skip this slide. Okay. Now coming to the risk factors. Okay, so who are the risk factors who may develop preeclampsia? Okay, so you have high risk factors, you have moderate risk factors. So lot of guidelines, they mention different risk factors. So remember one guideline, okay, your ACOG guidelines, most common guidelines. So what are the high risk factors? So if there is any history of preeclampsia, previous preeclampsia, chronic renal disease CKD patients, if the patient is chronic hypertensive, diabetes mellitus, or if they have any autoimmune disorders like your SLE or the antiphospholipid syndrome. These are the high risk factors. And even multiple pregnancies, that is also high risk factors for preeclampsia. Now coming to moderate risk factor. So primies are at a high risk, okay, and especially if the age is more than or equal to 40 years. Initially it was more than or equal to 35. Now I think because of the delayed pregnancies which are happening, I think they have extended it into age more than or equal to 40 years. If the patient is obese, BMI more than 35, inter-pregnancy interval of more than 10 years, and if there is any family history of preeclampsia. Okay, so these are the moderate risk factors for development of preeclampsia. Now coming to the pathophysiology. So just if when they ask pathophysiology, if you write this flow chart, that is more than enough, because to know in detail about the pathophysiology, I think it actually takes 5 to 6 slides, but we have just minimized to a single slide. So pathophysiology usually begins with, first word you should mention is there is abnormal placentation. What do you mean by abnormal placentation? That is, the trophoblasts fail to properly invade and remodel the spiral arteries. In order to know this in detail, you have to go through the normal remodeling or the placentation process. But just for the exam sake, so just write it as abnormal placentation. What do you mean by abnormal placentation? So what happens when there is an abnormal placentation? There is placental ischemia. Okay, so this placental ischemia, it triggers the release of some placental factors like anti-angiogenic proteins, which is known as SFLT1. Okay, that is released into the maternal circulation. So what does this protein do? It leads to maternal endothelial dysfunction, which is characterized by vasoconstriction and reduced blood flow. Okay, because of all these changes, you have the hallmark symptoms of the preeclampsia, like new onset hypertension, end organ damage, like proteinuria, kidney liver function dysfunction, and in severe cases even HELP syndrome. Okay, so please mention abnormal placentation, placental ischemia, release of anti-angiogenic proteins, which leads to endothelial dysfunction. What happens if there is an endothelial dysfunction? Vasoconstriction. So vasoconstriction causes hypertension. Vasoconstriction in other organs causes AKI or liver dysfunction or any other thing, and the reduced blood flow, right? So this is the pathophysiology. So if you want more marks, you can write the stages. Okay, the same thing is divided into two stages. One is the placental dysfunction and second is the maternal endothelial dysfunction. The same thing only. So you can just put one flower bracket and write it as placental dysfunction and the maternal endothelial dysfunction if possible. Okay, the same thing which I have told. Improper trophoblast invasion, failure of remodeling, placental ischemia. This in detail I've just mentioned it. Then release of anti-angiogenic factors, impaired angiogenesis and widespread vasoconstriction leading to end organ damage. Okay, simple. Now coming to the diagnosis. So what are labs you need to send in any suspected case of preeclampsia? Okay, so you need to send your CBC. Okay, So usually if there is an hemo concentration, it supports the diagnosis of your gestational hypertension without proteinuria. Then platelet counts, if it is less than 1 lakh, then yes, this patients might be even going into health syndrome. Your liver enzymes will be usually elevated. Serum LDH will be elevated. And in urine analysis, you're going to see your proteinuria. Measure your urine albumin creatinine ratio, 24-hour urine collection for proteinuria, and your serum uric acid will be elevated in some cases of gestational hypertension, and aka, as I told, serum creatinine levels. So these are the routine labs which you send for a patient of preeclampsia. Now, important is your screening of preeclampsia. So, at what stage you have diagnosed this patient has preeclampsia, and how to treat this patient is important. Okay, so only important points. Okay, so first trimester. Okay, so usually you screen for the patients. Okay, they come for ultrasound or something, so you screen for the patient. So screen at 11 to 13 weeks of gestation, any pregnant lady. Okay, so what you do is you do the uh, uterine artery pulsatility index you're going to measure. Okay, that would be the better one. Okay, see for the risk factors, measure the BP, and if possible, you do the Doppler of the uterine arteries. Okay, so patient is at high risk of preeclampsia, then please start. If you have diagnosed the patient as preeclampsia at this period, you start aspirin. You start aspirin. Okay, start before 16 weeks of gestation and you stop at 36 weeks of gestation. Okay, so this is the recommended treatment. So blue color is the recommended treatment if you diagnose patient in preeclampsia in the first trimester. And all the other pink ones are under development and resource dependent. Okay. Now, if you have diagnosed the patient at second trimester, okay, then you need to increase monitoring at 24 to 31 weeks of gestation. Okay, so only monitoring is required. Similarly, if you diagnose it in the third trimester, you require proper monitoring and then think of expectant management, whether delivery is required or you can extend the pregnancy. Okay, so this is how you screen the pregnant lady. So each stage, suppose this patient here is at low risk, it might go for a high risk in the second trimester. Okay, so 3 times you need to screen these patients for preeclampsia. Okay. Now, as I told, role of aspirin in preeclampsia. Okay, so it is the ASPIRE trial. So it is aspirin for evidence-based preeclampsia prevention trial. Okay, so this was a multicentric RCT. Okay, uh, where the trial included around 1700 women at high risk were identified by means of combined screening with the algorithm. There is one algorithm which is present, so they have identified that. So the convincing evidence that daily aspirin from the first trimester, it reduces the risk of preterm preeclampsia by 62% with no significant defect on the rate of term disease. And now if you see, most of the patients, even though they are not preeclamptic, as a routine, most of the obstetricians are actually prescribing aspirin for the patients. Okay. So that has become one of the now recommended drug in pregnancy. Okay, aspirin. Even though if the patient doesn't have any signs of preeclampsia. Okay, so ASPIRE prevention trial you need to remember. Now coming to the management. So management includes control of the BP and then about the delivery part. So what are the drugs that can be safely used in pregnancy? Okay, so the most commonly used drug is your centrally acting alpha 2 adrenergic agonist, that is your methyl dopa. Okay, so it inhibits vasoconstriction. So as I told, vasoconstriction is the main mechanism. So it inhibits vasoconstriction via central mechanism by reducing the catecholamine release. So this decreases the central sympathetic flow, which further decreases your systemic vascular resistance without decreasing your cardiac output. That is also very, very important. There is no impaired uteroplacental circulation, and hence this is not teratogenic. Hence, this is one of the drug in pregnant ladies to decrease the BP in preeclampsia. There are some side effects like fatigue, there is depression, poor sleep, dryness of mouth, and in around 5% patients, there could be an elevated liver enzymes. Okay, so this is the first group of drugs, the methyl dopa. Suppose if methyl dopa is not available or contraindicated, you can also try your other centrally acting alpha 2 agonist, that is your clonidine. Okay, so clonidine can also be tried similar to methyl dopa with regards to safety and efficacy. So preferred drug is methyl dopa, not available, any contraindications, then you can use clonidine. Okay, that is the first group. Now second group is your peripherally acting adrenergic receptor antagonists. Okay, so the most commonly used, which we all use, is the labetalol. So labetalol is a non-selective beta blocker with vascular alpha 1 receptor blocking properties. Okay, so what are the side effects with labetalol? It causes fatigue, lethargy, exercise intolerance, sleep disturbance, bronchoconstriction. They tell it is not teratogenic, but some studies have shown that there is some fetal growth restriction and low placental weight in patients who are on atenolol during the second trimester. Okay, so only drug that is better to be avoided in beta blockers will be atenolol. Otherwise, labetalol is very good. There is no teratogenic properties for labetalol. Okay. Now, second, coming to your prazosin, not most commonly used drug because it causes a lot of postural hypotension and palpitation. It is best used for those patients who have an underlying chronic kidney disease and then have a preeclampsia. Okay, such cases, prazosin would be a better option. Okay, so this is the second group. Now, third one is the calcium channel blockers. Okay, so the most commonly used calcium channel blockers are your oral nifedipine and the verapamil. Okay, so these are the second line agents. If the other drugs are not available, they are also not teratogenic. Okay, so mechanism of action, we all know, inhibits the influx of calcium ions to vascular smooth muscles, resulting in arterial vasodilatation. Okay, side effects, tachycardia, palpitations, peripheral edema, headache, and facial flushing. It is most of the drugs are class C drugs. Okay, no one is class A and class B. So every drug has some issues. So risk versus benefit is very, very important. Okay, the advantages of calcium channel blockers are it is compatible with breast milk. Okay, next group comes your direct vasodilators. Okay, like your hydralazine. Okay, so how it acts? It relaxes your arterial smooth muscles. Okay, this is also class C drug. It is not teratogenic, but there are a lot of side effects which are seen in the mother. Like it has severe headache. It causes very severe headache, nausea, and palpitations. Rare cases, they told that you can find neonatal thrombocytopenia. Okay, but it is very rare. Now coming to the last group of drugs, your diuretics. The use of diuretics in pregnant lady is controversial because it causes reduced plasma volume. Okay, but those patients who are already on maintenance diuretic therapy prior to pregnancy, they can be continued on this regime unless they develop premonitory signs of preeclampsia such as proteinuria. In such cases, stop the diuretic medications due to the concern that with the lower plasma volume characteristics of preeclampsia, further if there is hypovolemia, it may lead to stimulation of your renin-angiotensin system and it might worsen your hypertension. Okay, so diuretic role is still controversial. So these are the group of drugs which can be used in pregnant ladies for preeclampsia. As I told, for central actions, the preferred agent is methyl dopa. Alternatively, you can use clonidine. If you see, most of the drugs are C, 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 C. Okay, rarely it is B. Okay, then in beta blockers, preferred is labetalol, better to avoid atenolol. Calcium channels, preferred is nifedipine, alternative would be your verapamil. Then your direct vasodilators, diuretics. And important is contraindications. What is contraindicated? Your AC inhibitors are or ARBs are contraindicated in pregnancy because it is causes congenital heart defects and kidney defects in the fetus. Okay. So don't use, as I told, atenolol, propranolol, and your AC inhibitors and ARBs. Okay, so these are all the effects which will be seen on the fetus. Okay, so these are the dose of drugs that are available. Okay, so just remember about labetalol because we use it regularly. If possible, remember the dose of uh, methyl dopa. Not usually routinely used, but at least one of the drugs dose has to be remembered. Okay, so next, coming to the BP threshold. So when should you initiate treatment for preeclampsia, antihypertensives, and what should be your target? Okay, so there are lots of guidelines and societies which they have mentioned. So our thing is ACOG guidelines 2022. So what is the BP threshold for initiating treatment? So for a chronic hypertensive patient, your BP target is more than or equal to 140/90. For acute hypertension patient, the BP target is more than or equal to 160/110 mm Hg. But target treatment, I mean treatment target till how much you should get is not been specified by your ACOG. Okay, but your other societies have mentioned some of the targets. Like the International Society for Study of Hypertension in Pregnancy 2018 told that at least your systolic BP should be around at least around 140 and your diastolic BP should be around 85. Similarly, the other guidelines also, it is around 135/85 or 140/85. So target it as 140, less than 140 and less than or equal to 85 should be your treatment target. Okay. So then comes your seizure prophylaxis. Okay. This is still still this patient has no seizures. But is there a role of seizure prophylaxis in preeclampsia patients? So we are going to see. Okay, so what is the seizure prophylaxis usually we give for eclamptic patients? It is the magnesium sulfate. So magnesium sulfate is effective in the prevention as well as treatment of eclampsia in women with preeclampsia with severe features. So any patient with preeclampsia with severe features, you can give seizure prophylaxis in the form of magnesium sulfate. Okay, it does not prevent the progression of other organ involvement because of preeclampsia unrelated to seizures. Okay, the role of seizure prophylaxis in preeclampsia without severe features is unclear, and the ACOG recommends individualizing the decision on the basis of risk benefit ratio. Okay, preeclampsia with non-severe features, the role of magnesium sulfate is still questionable. Okay, it should depend upon each patient. Whereas preeclampsia with severe features, yes, you need to give seizure prophylaxis in the form of magnesium sulfate. Okay, so important trial for this is your MACPI trial. Okay, so this is seizure prophylaxis, not treatment. It is prophylaxis in preeclamptic patients. So magnesium sulfate halves the risk of eclampsia and probably reduces the risk of maternal death. Okay, if you use as a prophylaxis. There is no substantive harmful effects for mother and baby for short-term use. If you're using for short-term, yes, you can use magnesium sulfate for prophylaxis. Okay, this is the MACPI trial for prophylaxis. Just remember it. Then comes your eclampsia. So if any patient has an eclampsia, so for the first important thing is your ABC. Okay, airway, breathing, circulation. Then calm the environment. Give magnesium sulfate. Okay, delivery if the gestational age is above viability in the given clinical care setting. Suppose if the patient has not reached the viability, expectant monitoring plus rigorous monitoring. And for refractive seizures, even after magnesium, the other drugs that can be used are phenytoin. Phenytoin is the most preferred one. And usually patient should be managed in ICU and consider the neuro monitoring. Okay. Now, what is the role of magnesium sulfate in eclampsia? Okay, so pre-eclampsia done, now it is eclampsia. So this is the treatment of choice for seizure prophylaxis, magnesium sulfate. So ACOG recommended dosing, we will see it. So what is the dosing? So loading dose is given as 4 to 6 gram administered in an infusion pump over 20 to 30 minutes, followed by maintenance doses 1 to 2 gram per hour as a continuous infusion. Continue till 24 hours postpartum. Please remember the doses. Okay, so everyone, when we are asking in the practicals, most of them are getting confused. Okay, so please mention the range. Okay, so 4 to 6 gram loading doses over 20 to 30 minutes, followed by 1 to 2 gram per hour, usually given for 24 hours. Okay, that is the dose of magnesium sulfate. If there are recurrent seizures, then additional dose of 2 to 4 gram can be infused over 5 minutes. Okay, so you can give little fast. When you give after the first dose, the second bolus dose can be given over 5 minutes. Okay, you have even the IM options. Okay, your regimes, so many regimes are there. Pritchard, okay, so buspan regime. So IM option 10 gram initially as a loading dose, that is 5 gram IM in each buttock, followed by 5 gram every 4 hours. Okay. Um, so as I told, delivery, continue infusion 24 hours postpartum, post vaginal delivery, and if it is a cesarean delivery, begin infusion before surgery and continue 24 hours postpartum. Discontinuing prior to operative vaginal birth or cesarean section to avoid uterine atony or anesthetic drug interactions is not recommended. So please remember this. So as an anesthesiologist, we are all worried, right? Because it causes uterine atony or it causes a lot of muscle relaxation, additional muscle relaxation. If you give magnesium sulfate with anesthetic drugs, that is not there now. So do not discontinue magnesium sulfate. Okay. So coming to the mechanism of action of magnesium. So how does it prevent seizures? Okay. So seizures usually occur because of the excitotoxic neurotransmitters like our glutamate. Okay. So this glutamate usually it activates the NMDA receptors, which leads to massive depolarization of neuronal network and the bursts of action potential. So our magnesium may act to increase the seizure threshold by inhibiting these NMDA receptors, thereby limiting the effect of glutamate. Okay. So indirectly it is acting on glutamate by inhibiting the NMDA receptors. Okay. So that is a mechanism of action of magnesium sulfate. Now, when you're giving magnesium, we need to monitor for the toxicity of the magnesium, right? So, how do you monitor or how do you prevent the toxicity? So, first is any patient with magnesium sulfate infusion, please place a Foley's catheter and try to measure hourly urine output. Okay. Then confirm the normal serum creatinine. So, measure the serum creatinine. Then you have to check your two important things. One is your deep tendon reflexes and next is your respiratory rate. Okay. So pre-administration respiratory rate should be at least 16 per minute. Your patellar reflexes should be present and urine output should be at least 30 ml per hour over 4 hours. If you meet these criteria, then you can safely start your magnesium sulfate infusion. Okay, so most of the patients, preeclamptic patients who have AKI, their urine output will be less. So in such cases, try to avoid magnesium sulfate. So see for a prerequisites. If those are met, then start your infusion and you need to monitor your urine output, your serum creatinine, your patellar reflexes and the respiratory rate. Okay. And then comes the important monitoring, your serum magnesium levels. So now the guidelines are telling that serum magnesium levels are not routinely required. You only monitor the levels in the setting of renal dysfunction and or absence of patellar reflexes. Okay, and try to maintain the serum concentration between, remember one thing, okay, don't get confused, either remember in mg per dl or milli equivalents per liter. Okay, so in mg per dl it is 5 to 9, in milli equivalent it is 4 to 7. Okay, so this is very, very important. You need to remember one value which is mostly commonly practiced in your lab. You can remember that. Okay, now the predictive symptoms of magnesium sulfate toxicity. So if the levels are more than 9 mg per dl, okay, then there is a loss of deep tendon reflexes, more than 12 respiratory depressions, more than 30 cardiac arrest. Okay, so what is the, if you find there is a magnesium toxicity, stop the drug and give your calcium gluconate. Okay, so until respiration begins to counteract the effect of magnesium sulfate, you can give your calcium gluconate. Okay, so in short, so how to manage any patient of preeclampsia. So hypertension pre-pregnancy, you treat with any antihypertensives that are available, avoid ACE inhibitors, okay, and try to screen the patient. This is pre-pregnancy and the patient is planning for a pregnancy, then you need to treat this patient and avoid your ACE inhibitors, ARBs and your atenolol. Then hypertension early pregnancy, treat with or start with aspirin. Preeclampsia identified at less than 30 weeks, 37 weeks of gestation, treat the hypertension and then see whether the patient has severe symptoms, non-severe symptoms. If the patient has severe symptoms, give even the magnesium and then decide upon the viability of, if you're planning for emergency um, um, delivery, if the patient has any other complication, do the delivery, or you're planning it in a day or two, then give the steroids for fetal lung maturation. Preeclampsia identified more than 30 weeks of gestation, treat for hypertension and consider inductions once reached more than 37 weeks of gestation. Postpartum care is also very, very important because the patient might have the episodes of seizures for even around 12 weeks also, 6 to 12 weeks. So you need to have a proper postpartum care. Okay. So the in short is about the management of hypertension in pregnancy. What should be the what should be the BP control? What are the drugs that has to be used? What is the seizure prophylaxis? Okay, so this in short is your one slide or two slides which will you can write in your exam if possible. Okay, thank you.